A very good afternoon to everyone. On behalf of Walters Kluwer, a warm welcome to our speakers and attendees of this radiology webinar under a medical ed series. Our topic today is imaging of SIH, IIH and NPH disorders of the intracranial CFS flow changing perspective. Our speaker today is Dr. Hrishikesh Kale, who is Senior Consultant Radiologist, Kogilaben Dhirubhai Ambani Hospital, Mumbai. Also, we'll be taking all questions at the end of the webinar, and I request you to please post all your questions in the Q&A panel of this event. We'll try to address the maximum questions. Please also provide us your feedback via a link which we'll post in the chat section of the webinar. Now we begin our session and I hand over to Dr. Hrishikesh Kale and request him to please start sharing his screen. Dr. Kale, you can maybe please start sharing your screen, sir.
Yeah, I'm doing that right now. Can you see my screen?
Yes, sir.
Okay.
Sir, can you please remove some images which are there?
Yeah, I'm doing that right now. Is that better now?
Yes, sir.
Okay. Okay, so let me get started. Thank you to Walters Kluwer for inviting me for this talk, and thank you for all the attendees. So good evening to all of you. So let me start off. So basically, CSF is a clear proteinaceous fluid that surrounds the brain and the spinal cord. It occurs in most mammalian central nervous systems. So the traditional view is that CSF is formed predominantly in the choroid plexus. The CSF then goes from the choroid plexus, which is present within the ventricles, then circulates to the fourth ventricle, where in the fourth ventricle it exits from the median aperture, which is also known as foramen of Magendie, and lateral apertures known as foramen of Luschka. It then enters either into the basal cisterns or it enters into the central canal of the spinal cord. So at any, and then from the basal cisterns, it extends to the cerebral convexities from where it drains into the arachnoid granulations. So at any point of time, there's around 125 to 140 cc's of CSF within the subarachnoid space and the ventricular system. A total of around 500 cc's is produced daily. So you can see that there is a lot of recirculation of this CSF, redistribution of the CSF, which is occurring. So how does this movement of CSF occur? So basically during systole, the brain and the vessels swell up and they push the CSF from the cranial to the caudal direction. And then in diastole, the reverse happens. There's also small contribution by the ciliary action of the ependymal cells. So basically, most of this motion within the within CSF spaces occurs as a result of pulsations during systole. So now let's first to understand SIH, which is spontaneous intracranial hypotension, and idiopathic intracranial hypertension. You need to know what is the Monro-Kelly hypothesis. So according to this hypothesis, the volume of your intracranial contents is fixed. Since it's the calvarium is bony, the volume which is inside the calvarium cannot be changed. So this volume, the intracranial volume, is basically composed of the volume of the brain parenchyma, the volume of CSF, and the volume of blood, both arterial and venous. So because it's a fixed volume, there's only a limited ability to compensate. So if any one of these components decreases, something else has to take its place. So if there is loss of CSF, then the blood has to increase intracranially to accommodate that, to fill up that area, since a vacuum cannot exist, and brain parenchyma volume remains about the same. So once we understand this principle, it's easier to understand what happens in SIH and in increased intracranial, in idiopathic intracranial hypertension. So what is SIH? So SIH is a condition which is characterized by low CSF volume which is secondary to leakage of CSF. So usual measurements which are for this diagnosis are CSF pressure, opening pressure less than 6 centimeters of H2O. The typical symptom is orthostatic headache. So ICHD is basically the international classification of headache disorders. So they have defined orthostatic headache as that caused by low CSF pressure or CSF leakage, usually accompanied by these different symptoms such as neck pain, tinnitus, changes in hearing, photophobia, and nausea. The typical symptom is orthostatic hypotension, orthostatic headache. That is, the headache goes away or becomes less as you lie down, but increases in the sitting or in the standing position. This type of headache also should remit after normalization of the CSF or after sealing a CSF leak. So there are some diagnostic criteria for SIH. So it is under the category 7 of non-vascular intracranial conditions producing headaches. So any of these four criteria, once these four criteria are fulfilled, you can categorize this headache as SIH. So which are the four criteria? Any criteria fulfilling criterion C. So C is criterion C is something which defines qualitative headache characteristics. Two of these should be present. Then I want to bring your attention to the second point where you need a low CSF pressure that is less than 60 millimeters of H2O. And the second point in this is evidence of CSF leakage on imaging. So imaging does play an important role in this diagnosis. The other importance of imaging is to make sure that there is no other cause for these headaches. The other important point is these headaches should be in temporal relation to low CSF pressure. So suppose a patient, although this is commonly idiopathic, there are also conditions in which similar findings may be seen, such as after a lumbar puncture. So after a lumbar puncture, if you have similar clinical findings, the headache should be in temporal relation to the event, such as when the lumbar puncture was performed. So what are the typical causes for SIH? So bony defect in the skull base, which with leakage of CSF from the dura can produce SIH. Nerve root sleeve diverticula. A disc ossified can sometimes produce a rent within the dura, which then produces SIH. A fistulization between the CSF and the venous system. Patients with connective tissue disorders, their dura and the coverings of the nerve root sleeves are especially prone for leakage of CSF. And then traumatic, either related to an LP or just trauma or post-operative, such as after endonasal surgery. So although SIH is defined as decrease in intracranial pressure less than 6 centimeters of H2O, one third of these patients may have normal pressure or even increased pressure. So that's something to be to remember. And why is that? Because sometimes these patients have intermittent CSF leakage, so their pressure can the pressure can vary a lot, going from low pressure to normal pressure to increased pressure. So thing to remember is that nerve root sleeves have arachnoid granulations and venous drainage. So these can be the sites of CSF leakage. So whenever we are evaluating a patient for SIH, what are the main questions? Is there presence of SIH is the first question. And what is the site of this leakage? So what are the typical MRI signs that you see? So there's a mnemonic known as SEEPS, which is very widely known mnemonic. So what does this consist of? Sagging, enhancement, engorgement of vessels. Enhancement refers to the dural pachymeningeal enhancement. Then prominence of the pituitary gland and subdural collections, either hygromas or hematomas. Typically what happens is that with CSF leakage, there is descent of the brainstem structures, and this might produce a Chiari-like appearance with a very tight appearance of the seen at the foramen magnum. The floor of the third ventricle may also drop, and you may have a flat belly of pons, a prominent pituitary gland. Rarely, in long-standing patients with SIH, you may even get superficial siderosis. So how do you, before I go on to the cases, how do you go about making this diagnosis? So suppose someone has referred a patient to you for diagnosis of SIH. So what do you do? So the first investigation to be done is an MRI of the brain. So on MRI of the brain, if you see any of those findings which we just described, that can be a pointer of this being SIH. Second question to ask is this, does this patient have otorrhea or rhinorrhea? If the patient does have otorrhea or rhinorrhea, the next test would probably be a CT or an MR cystonogram. If there is no known otorrhea or rhinorrhea, the next step is evaluating the rest of the neurospinal axis. So you'll be evaluating the spine. So for evaluating the spine, you can do a CT myelogram. So traditionally we used to do a CT conventional myelogram to evaluate for the site of leak and even look for any collections within the spinal canal. Newer techniques involve a dynamic scan. So basically what is done is the needle is placed into the thecal sac and then contrast is injected as at the same time you are scanning continuously over a period of 3 phases. This can basically localize the site of leakage or at least help assist in evaluating the site of leakage. Another technique which is used is digital subtraction myelography, where this is done under fluoroscopy. And then as you do a digital subtraction angiogram, you can do a digital subtraction myelogram to evaluate the site of leak. So typically these two techniques, CT myelogram and digital subtraction myelogram, are done when there's a fast leak, so that you want to capture the site of leak, which is the whole purpose for doing this exam. MR myelogram, on the other hand, is typically performed for slower leaks where you are trying to be more accurate, and because of the greater soft tissue resolution, you can try to pinpoint the site of leakage or try to evaluate the diverticula to look for any surrounding collection. So this is the typical way in which you can go about trying to evaluate SIH. So among there are various signs which are which are there for evaluating SIH, but two signs which have been found to be the most sensitive and specific include a small mammalopontine angle less than 5.5 millimeters and a small pontomesencephalic angle of less than 50 degrees. So on the left side you have an image where you can see that there is sagging of the brain, and the angle, the pontomesencephalic angle in this patient is just 25 degrees, whereas on the right side you have the second image where you can see that because of sagging of the brain, the mammalopontine distance has reduced. I must warn you, however, that in many patients you will not get such classic findings and you may have something in between. So how do you treat these patients? So these patients can be treated by having them lie in bed, giving them adequate fluids. Vasoconstrictors such as caffeine might help. That usually plays a role by acting on the adenosine receptors, which can help with these types of headaches. The second treatment is blood patch. This is especially important in patients where you cannot find a definite site of leak. You can do an empiric blood patch and repeat it. If the headaches improve but do not completely go away, repeat it again after a week or two, and then again give a higher volume of this blood patch. The third way is, if you do localize a site, the site of leakage, you can do what is known as a targeted CT guided blood patch placement or a fibrin patch placement. So in this, if you see say a leaking diverticulum at one of the spinal levels, you can target that with CT and then inject blood or fibrin into that area. The exact mechanism of how the blood patch acts or how fibrin works is not definitively known. It's believed to produce an inflammatory reaction around that area and decrease leakage. And then the third way of treatment is by surgery. If there's a large rent in the dura, these patients can get operated and the dural tear can be repaired. So let's go over some of these cases which we have seen in our hospital. So this is the first case. So on the left, you have an axial T2 weighted sequence, and on the right, you have an axial T1 weighted sequence. So You can see here that on both sides there is presence of bilateral subdural collections which are hyperintense on your T2 and isointense on your T1. These are bilateral and symmetric. The ventricular size is fairly small. This is a sagittal T2 and a post-contrast T1 sagittal image. On the left, you see that there is sagging of the brain parenchyma. You can see there is a descent of the optic chiasm. There is prominence of the pituitary gland, a flattening of the pons there, and the pontomesencephalic angle, which we described before, has definitely reduced. The other thing that you see on the image on the right side is there is fairly diffuse pachymeningeal enhancement. It is a smooth type of an enhancement. So this again points to presence of something like SIH. These are the axial T1 and the coronal T1 weighted sequences. Again, you can see diffuse pachymeningeal enhancement, which is not nodular. It is very smooth. So this should immediately point you in the direction of possible SIH. So this is our second case. So what procedure do you see here? So this is basically a CT cisternogram. So on this CT cisternogram, what you are seeing is there's presence of contrast in the, if you can see my arrow, there's contrast within the subarachnoid space. So this contrast was injected through a lumbar puncture, and the patient was given a head low, and then this contrast was manipulated into the basal cisterns, into the anterior cranial fossa. And then you can see that there is a defect in the cribriform plate on the left side with leakage of contrast through that cribriform plate. So this is one of the common sites where CSF leaks can occur through the cribriform plate. This is a sagittal T2 weighted sequence, which again demonstrates the same thing. You can see there is this hyperintense signal here is of CSF, and then there is leakage of this CSF through the defect. Again, the same thing demonstrated on the right side. So one important thing that you can evaluate is how do you separate that fluid within the ethmoid air cells from some proteinaceous material. So one thing you can do is if you obtain a coronal T2 and a coronal flare sequence, you can see that the that fluid which is present in the left sided ethmoid air cells is suppressed on the flare sequence. So this suggests that this has a CSF-like signal intensity, and you can surmise that this may be secondary to SIH. So now our third case, the third scenario which we commonly see is patient has intracranial findings suggestive of SIH, but the patient does not have any rhinorrhea or any and no otorrhea. So in these patients, it's important to evaluate the spinal axis. So here on the left side, you have the SAGE T2 weighted sequence. And on this SAGE T2 weighted sequence, you can see there's an area of increased signal intensity along the ventral aspect of the cord. And if you take a look at the axials, there's a fluid collection in the ventral epidural space. Okay, so this is the axial T1 and an axial T2 weighted sequence through the thoracic spine. Again, you will see that there is presence of fluid surrounding the thecal sac. You can see the margins of the dura, and there is presence of fluid behind the thecal sac, the dura of the thecal sac. So this is the third type of scenario where you can so this is a sagittal T2 weighted sequence in the same patient. One important finding which you may see is typically dural venous sinuses usually have either flat or concave margins. In some patients, if you see this convex margin along the margin of your transverse sinus or your sagittal sinus, that can suggest presence of engorgement of the veins. So this may suggest presence of SIH. This is not a very specific sign, but this is something you can look for when you're trying to evaluate a patient for SIH. As I told you before, not all signs will be present in all patients. So it's important to try to get as much information as you can from your imaging. So this is the fourth scenario. So this is not really spontaneous intracranial hypotension. This is more of a similar picture which you see in patients. So this patient had a shunt placed for NPH. You can see a right parietal shunt which extends into the right lateral ventricle. A patient was recently operated. After a few months, he presented with headaches and disorientation. And you can see he has bilateral subdural mixed density fluid collections, and the ventricles are almost completely effaced on this evaluation. So what do you think has happened? So basically, there is over drainage of CSF producing intracranial hypotension. So this is the same picture that you see in SIH, where with bilateral subdural collections and over drainage of CSF producing these findings. So there are two types of shunts which are commonly available. There are your programmable shunts and your non-programmable shunt. So this is a programmable shunt, so you can change the shunt settings and you might be able to deal with this issue without any further surgery. So the shunt settings were changed, and with changed shunt settings, the bilateral subdural collections resolved. Excuse me for a second. The bilateral subdural fluid collections resolved with re-expansion of the lateral ventricles. So now let's go on to our next topic. What is idiopathic intracranial hypertension? So this is usually characterized by an opening pressure greater than 25 centimeters of H2O in normal sized individuals and 28 centimeters of H2O in obese individuals. So the typical findings are headaches and vision changes. There's a strong female predominance, more commonly observed in overweight women of reproductive age. So what are the diagnostic criteria for IIH? So the diagnostic criteria include new headache or significant worsening of one of the pre-existing or significant worsening of a pre-existing headache. Again, fulfilling the criteria C, which we have seen before. Excuse me. So again, there are no imaging criteria which have been described for IIH. However, as you can see in the fourth point here, pulsatile tinnitus and papilledema, headache accompanied by these does fit this criteria. So if you see any of the eye signs which you can see on MRI for papilledema, those can be extremely helpful in making this diagnosis. Again, imaging is useful in excluding other diagnoses, such as excluding presence of a tumor or an infection or a dural venous sinus thrombosis. If there is presence of dural venous sinus thrombosis, then this cannot be categorized as IIH. So what are the MRI findings which you typically see with IIH? So the eye signs include papilledema, where you can see a bulging of the optic disc, dilated CSF sleeves around the optic nerves, optic nerve tortuosity, flattening of the sclera, posterior aspect of the sclera, an empty cella. You can have a large Meckel's cave, prominent arachnoid granulations and rounded lucencies. The ventricles are typically slit-like, they are non-dilated. One of the etiologies which is thought to be present is stenosis of the transverse sinuses. We will get into that just in just a bit. So it's basically like a chicken and egg dilemma. Does the increased intracranial pressure produce a compression of the dural venous sinuses, or does the presence of stenosis of the dural venous sinuses produce the increased intracranial pressure? There is newer evidence which suggests that venous stenosis and obstruction is the main cause of idiopathic intracranial hypertension. So how are these treated? So conservative management. So weight loss is a big um, is a big one here. So weight loss can significantly reduce the can really help in treatment of patients with IIH. So what happens? If conservative management fails, then the other option is repeated LPs or placement of a shunt. The main complications related to increased intracranial idiopathic intracranial hypertension is vision loss because of optic nerve atrophy and optic nerve compression. So some people perform a optic nerve sheath fenestration to help in preventing this dreaded complication. There are mixed results with venous stenting. There are some people who advocate a styloidectomy along with venous stenting in treatment of increased intracranial pressure, idiopathic intracranial pressure. but these are not commonly done. So the most effective treatment is actually conservative. With weight loss, many patients' symptoms will improve. So let's look at some cases here. So the first case here is on your left side, you have a coronal T288 sequence where you can see an empty sella. The sella is expanded, and just to the right of the sella, you can see there is an area of abnormal signal within a lateral recess of the right sphenoid sinus. And then the subarachnoid space just adjacent to that is effaced, and you can see some herniation of the brain through this defect, herniation of brain and meninges through this defect. So this patient initially presented with increased intracranial pressure and had intermittent leakage of CSF. So on the right side, you have another axial T288 sequence, which shows dilation of the CSF sleeves around both optic nerves with flattening of the sclera and mild bulging of the optic nerve head into the posterior aspect of the sclera. So this is the coronal T288 sequence, which again shows the dilated CSF sleeve around both optic nerves. So a CT was obtained in this patient, and this patient basically had stigmata of both increased intracranial pressure as well as had a CSF leak. So the CSF, the increased intracranial pressure was seen as presence of an empty sella, presence of dilated CSF sleeves around both optic nerves and papilledema. And then through this defect in the lateral recess of the sphenoid sinus roof, there was herniation of brain contents and meninges with a CSF leak. So I'd mentioned to you that in patients with SIH, you can have low, normal or increased intracranial pressure. Some of these probably fall in this category where they are intermittently having leaks, and one of the causes of the SIH is increased intracranial pressure. This is the second case. Again, here you can see there is a prominence of the CSF sleeve around both optic nerves and an empty sella. So not all of these findings will be present in all patients. Sometimes you can have dilation of the Meckel's cave as well. So in our third case, let me just get to the third case. So in our third case here, what we see is there's a dilation of the Meckel's cave. So you may not always see an empty sella. You may sometimes see dilation of the Meckel's cave rather than an empty sella. So in the previous case, you can see there is some narrowing of the transverse sinuses on both sides. So typically you can have various combinations of these. You can have a hypoplastic transverse sinus on one side, a normal size transverse sinus on the opposite side with a stenosis, or you can have hypoplastic bilateral transverse sinuses. These can occur in various combinations. So it's important to evaluate the dural venous sinuses in patients with idiopathic intracranial hypertension. So let me just go over the signs one more time. So the main signs in increased in idiopathic intracranial hypertension include the eye signs, which are papilledema, dilated CSF sleeves, tortuosity of the optic nerves, and flattening of the sclera, empty sella, enlarged Meckel's cave. Usually the ventricles are slit-like, and prominent arachnoid granulations, which you'll see on CT, and you may have stenosis of the transverse sinuses. If there's presence of thrombosis of the venous sinuses, this does not fit the category of IIH. There's one last interesting case which I wanted to show you. So this is a sagittal T288 sequence in the midline where you can see an empty sella. Had some prominence of the optic nerve sheaths, but what we observed on the MR venogram was there was an abrupt change in caliber of the jugular vein. So this is the sigmoid sinus here. This is the jugular vein. This is the carotid artery on the right side. Same thing on the left side, sigmoid sinus and the carotid artery. So this is the section right below the section which I just showed you. This is the carotid artery on the opposite side. And then the jugular veins were almost slit-like. So sometimes what happens is that a large styloid process can sometimes produce a compression of the jugular veins. So some people have advocated performing a styloidectomy and stenting to help in treating these types of specific types of idiopathic intracranial hypertension. So these are the MIPS on the same patient where you can see that the superior sagittal sinus, transverse sinuses, and the sigmoid sinuses are patent, but there is a stenosis of both upper interjugular veins as a result of a prominent styloid producing narrowing. Okay, so what is the new hypothesis regarding IIH? So the main hypothesis is that there is decreased venous drainage. So this decreased venous drainage produces increased venous pressure. So this is only in a subcategory of patients of SIH and IIH. So this decreased venous drainage and increased venous pressure produces increase in the CSF pressure. So once the CSF pressure is increased, if they have no leak, they usually go on to getting IIH. Whereas if there is a CSF leak, these patients then go on to get SIH. So in patients with SIH, always keep a lookout if there are signs, other signs which suggest presence of IIH in these patients. Any signs to suggest idiopathic intracranial hypertension. So these two entities are now, at least in some patients, thought to be linked with each other. So now that we have covered this, let me go on to the next subtopic. So I had mentioned to you before that the traditional concept of how the CSF flows was basically CSF is produced by the choroid plexus, goes through the lateral ventricles, exits from the lateral ventricles, goes into the subarachnoid spaces of the convexities, and then gets absorbed by the arachnoid granulations. So now it is believed that the CSF is also formed in the ependymal cells in the Wernicke-Robin spaces and in the brain parenchyma, in the interstitial space of the brain parenchyma. So this occurs both via passive as well as active transport. So this the active transport and passive transport both contribute to formation of CSF in these other areas. So just like your CSF production is debated, there's also debate regarding CSF drainage. The traditional view is it just drains through the arachnoid granulation, but the new finding is that there is presence of lymphatic tissue within the dura mater. So now the current thought is that there is also a CSF reabsorption along the subarachnoid spaces of the exiting cranial nerves as well as along the venous portion of the Wernicke-Robin space of the arteries and veins, which then can extend, which can then drain through the to the dura, which covers the duravenous sinuses. So they are basically going back. It is felt that there are three other sites where some of that CSF may be formed. That is the ependymal cells, VR spaces, and in the brain parenchyma interstitial space. And there are other sites where CSF can be reabsorbed, such as along the subarachnoid space, as well as along the lymphatics, which are along the dura. So all of this all of these findings have come into focus over the last 10 years or so. The first experiments were performed by Dandy, in which he did a plexectomy, in which he saw that there was very little production of CSF after the removal of the choroid plexus. But these are all fairly recent findings. So just a quick word on the lymphatic system. So there is no lymphatic system in the CNS to remove the waste products. So they have hypothesized presence of a lymphatic system. So the postulation is that CSF enters along with the perivascular arteries and extends along the subarachnoid space, which surrounds the uh, into which the arteries enter. These arteries are lined by astrocytic end feet, glial limitans, which has aquaporin 4 channels. So basically, the blood comes through these arteries, and then CSF, by like we mentioned, CSF by active and passive methods is filtered out into the interstitial space. The CSF picks up waste and it exits the interstitial space via the same channels, which line the venous portion of the Wernicke-Robin space. So what you basically have is there's both production of CSF as well as reabsorption of CSF, and this is this exits out then through the venous Wernicke-Robin space. So the water, that is the CSF, can move freely between the interstitial into the interstitial space from the subarachnoid space, but it cannot move from the ventricular compartment. That's only true if the ventricular pressure is normal. If there is increased ventricular pressure, then CSF can move from the ventricles into the interstitial space. So these findings, so this movement of CSF can occur from the subarachnoid space into the interstitial space, okay, and not from the ventricular compartment into the interstitial space without presence of hydrocephalus. So all of this entire process occurs due to presence of arterial pulsations. Okay, so let me just go back since this is a little bit complicated. So CSF, which we thought was just produced by the choroid plexus, is no longer thought to just be produced by the choroid plexus, but other spaces also are believed to be are also believed to form CSF. Drainage can also occur other than through arachnoid granulations, can also occur through the subarachnoid spaces which surround the exiting cranial nerves, as well as along the dura, which lines the meninges, rather the lymphatic tissue which is present within the dura mater of the meninges. Okay, and then we talked about the glymphatic system, where the CSF is filtered out through the vessels in the subarachnoid space and enters into the interstitial space, and then exits again through the by the same process, where the CSF picks up the waste and is expelled through the Wernicke-Robin, the venous portion of the Wernicke-Robin space. And all of this is regulated by arterial pulsations. So this is basically earlier concept that choroid plexus forms a CSF, and it circulates through the ventricular system and the cisterns and then is reabsorbed by the arachnoid villi is incorrect. Basically, there is sort of a balance which is occurring between the blood, the Wernicke-Robin space, the interstitial fluid and CSF, and the drainage also occurs through lymphatics uh, as well as along the subarachnoid space along the cranial nerves. So slightly complicated topic, but it will help you understand the basis for your NPH. So what is NPH? So NPH is a triad of gait apraxia, ataxia, urinary incontinence, and cognitive impairment. So the importance of diagnosing NPH is that this is one of the few causes of reversible dementia. So what are the findings that you typically see? You have CSF spaces which are dilated out of proportion to sulci, whether it's the ventricles or a few dilated isolated sulci or the sylvian fissures, they are dilated out of proportion to the rest of the sulci. So what is DASH? So DASH is disproportionately enlarged subarachnoid space hydrocephalus. So typically, if you look at a coronal, if you look at the lower portion of that coronal T2-weighted sequence, if there are dilated sulci in the along the sylvian fissures and as well as in the lower portion of the brain parenchyma and relative effacement of the sulci at the frontoparietal convexities, this can suggest presence of DASH. Another index which has been reported is an Evans index. So Evans index greater than 0.3, you can suggest presence of hydrocephalus. Then callosal angle normal is between 100 to 110 degrees, but if it's less than that, then you can again it adds to evidence of there being NPH. Upward bowing of the corpus callosum. Now, prominent aqueductal flow void used to be seen previously when there were spin echo sequences. It used to be seen very prominently, but now with your fast spin echo sequences, you may or may not see the aqueductal flow void. This aqueductal flow void is produced due to presence of hyperdynamic CSF, which produces a flow void, just as you see with flow void for arteries. So what is the Evans index? Basically, this index is measured, you're measuring the margins of the lateral ventricles and then comparing it with the inner margin, inner table of calvarium. And if that is greater than 0.3, this can suggest presence of hydrocephalus. And then the callosal angle, again, there is, if the callosal angle is acute, this usually suggests presence of hydrocephalus NPH. So how do you treat NPH? So there is so different geographic locations, they treat NPH differently. In some areas, if there is enough evidence on purely based on imaging and the clinical signs and symptoms suggest presence of NPH, some places will directly go for placement of a VP shunt, whereas other places will be a bit more cautious. They will do large volume taps and then see if there is any improvement in the patients. The third way to do this is to place a lumbar drain. So you place a lumbar drain, you admit the patient for 2 days, you repeatedly remove some of that CSF. It acts kind of like a trial of placing a VP shunt catheter. And if there is significant improvement, these patients go on for placement of a VP shunt. Okay, so let's look at some cases here. So this is a coronal T2 weighted sequence and an axial T2 weighted sequence. You can see on this coronal sequence, there's a dilated sylvian fissures and dilated sulci. If you divide this coronal image into half, you can see that the sulci along the lower portion of this image are dilated far more than at the top of the image in the frontoparietal region. So this is typical appearance for your DASH. And you can also see that the ventricular system is dilated a lot, is dilated out of proportion to the dilation of the sulci. So one technique which is advocated but which is controversial is using CSF flow evaluation. So the reason why this has fallen out of favor is because the values which are obtained can vary with different machines and in different locations. So what is advocated now is you perform CSF flow study on a group of normal, say 20-25 patients, find out what would be your normal aqueductal systolic velocities and volumes on your machine in your location, and then scan for your NPH. So the reproducibility of these findings is difficult. So here you can see these are axial sections to obtain a CSF flow study. You can see an area of increased signal intensity here. This is the aqueduct, and this drop signal on this subsequent image on the right side. So basically there is presence of pulsatile flow is what you can see between these two images. So you can place an ROI and then get a measurement of this of the stroke volume in this location. But you have to be careful how you position, how you obtain this. Even as so, it has to be ideally perpendicular to the aqueduct. Even a small change in this angle can significantly change your measured velocities. So this is a very technically challenging way of evaluating for NPH. So it has fallen out of favor in many places. But this is something which can be useful in evaluating for NPH. Now let's look at some other commonly seen cases. So this is a patient who had a CT. You can see massively dilated ventricular system, which is way out of proportion to the dilation of the sulci. Then the sulci in the high frontoparietal region, especially the paramidline sulci, they are effaced. Okay, then this is another case where you have all the findings of NPH. NPH compared to SIH and IIH, the findings are fairly typical findings. There's not a lot of variation in findings. So dilated ventricles out of proportion to the sulci, a few isolated dilated sulci, effacement of the paramidline sulci in the high frontoparietal region are the typical 3 or 4 findings which you see with NPH. So where do you obtain the callosal angle is another question which frequently comes up. So you're basically looking at the anterior commissure and looking at the ACPC line and drawing a perpendicular at the level of the anterior commissure. That's where you should ideally perform where you should ideally obtain your coronal to get a proper callosal angle. Again, variation in the plane in which you obtain that coronal can change that angle drastically. This is another patient with NPH, severely dilated ventricles and normal appearing sulci. Okay, so this is a newer technique which they have used in evaluation for NPH. This technique is similar to your arterial spin labeling. So on the top is your time slip technique used in a normal patient. You can see reflux into the lateral ventricle, okay, into the frontal horns of the lateral ventricle. The middle panel is what you see with NPH, where you will not see that reflux into the lateral ventricle. Whereas the last panel, the lowermost panel is in a patient with a VP shunt catheter, where you again see that the reflux into the lateral ventricle returns once this patient is shunted. So this is your time slip technique, which is similar to your arterial spin labeling, which you use for MR perfusion evaluation. Then this is another topic I wanted to discuss since this is related with NPH. So benign external hydrocephalus, these kids usually present around 1 year of age with enlarging head size. There's increase in volume of the subarachnoid space and maybe slight increase in size of the lateral ventricles. So this usually resolves by 2 years of age. So this is usually thought to be a result of the arachnoid granulations not being mature enough, which is why you get benign external hydrocephalus. But this benign external hydrocephalus has now been linked to NPH. So they believe that these patients who have NPH at a later age, in their childhood, they had benign external hydrocephalus. And then with subsequent development of small vessel ischemia in adulthood, they developed NPH. So the proposed mechanism by which this happens is that CSF, when in childhood, when they get benign external hydrocephalus, that CSF crosses the ependyma into the interstitial space and is transported out into the venous Wernicke-Robin space via the aquaporin 4 channel. That's why I have discussed all of this in your lymphatic pathway. So this pathway can become impaired with development of small vessel ischemia. So with small vessel ischemia, what happens is that there is demyelination. So with loss of myelin and lipid, what you have is increased protein in that area, and that protein produces increased resistance to your flow of CSF. So because of that increasing resistance, these patients are thought to then develop NPH. So this is regarding your benign external hydrocephalus and NPH. I think that is the end of my talk. Thank you so much, and then we can answer some questions now.
Thank you so much, Dr. Kale. Thank you so much for an exhaustive presentation from your side. We do have, sir, some questions, but before getting to the questions round, sir, I would like to know that as you are also, one of the editors of our new release product, Radiology Review Manual from Dan Hart. So I just want to know, sir, for the radiologists, practicing radiologists, as far as the postgraduates in radiology, how this book is important. For that also, sir, I would like to also
So
share
this
here.
book has been, so basically this book has been around for a long period of time. We knew about this book during our residency. What I thought was that the differential diagnosis was a little bit skewed towards United States or towards the Western countries. So many of the differentials were did not include say things like tuberculosis or cysticercosis. The other thing which I thought was lacking in the older editions was that newer versions of the reporting system were not available, such were not are not mentioned in the book, such as LIRADS and BIRADS. So those were not there. One thing which we have added in this book at the end is an index of the differential diagnosis, which is also not there in some of the older editions. So overall, we had tried to update it and then tried to include differentials which are more pertinent for South Asia rather than for the Western world.
Okay, sir, if you can just look, I hope you can see the screen that I have right now showing.
Yes, I can see the screen.
So, sir, when I look at the book, this book is actually, so what we have done, sir, we have produced the summary chapter of this book. and we can see there are a lot of good, I would say, in terms of the new things which you have actually added to this particular title. And also, as I discussed to you in the morning itself, that there are also new things which you have added in terms of the topics and the subjects, the
Exactly. So we
sections.
have tried to update this book, and so it's we have not written this book. We have basically edited it and tried to add things which I think will add more value to for residents as well as to other practicing radiologists.
Okay.
Um, yeah.
Okay, great, sir, great. Also, sir, if I look into the Q&A panel of this session today, it itself is that we do
Mhm.
have certain questions here, which I'll just ask you,
Okay.
which is, just hold on, sir. So the question, sir, that what is the role of CSF flow and studies, as well as CSF flow void in aqueduct in IH and hypotension?
So CSF, so actually for most of the CSF flows, so you also want to rule out presence of any aqueductal stenosis. That's one thing I forgot to mention, that in patients with NPH, you also want to rule out any aqueductal stenosis. So your CSF flow studies can help in that. CSF flow studies don't usually help in SIH or IIH, diagnosis of SIH and IIH, unless you are looking at the spine. So in spine, presence of adhesions is something which you may be able to see with a CSF flow study. But otherwise, other than that, there's no real added value to doing a CSF flow study um, for SIH and IIH.
Okay. Also, sir, as far as the booking is concerned, because we have got very good feedback of the product, this particular title in the market itself. So it is, sir, should I say that this book itself is a must-have because it's a totally new, just published now, like last year itself in the fag end of the year. It's a must-have for the all the postgraduates who are studying radiology.
Yeah, absolutely. It's a good read. The differentials especially are all together in one place, and like I said, we have adapted the differentials for South Asia.
Okay, great, sir, great. Well, thank you so much, sir. Thank you so much for your time. By looking into the time, also we have also run out of the time to today. But thank you so much, sir, for joining us and giving us this brief and very elaborated presentation on this subject itself. And also would like to thank my attendees who has taken a time out, all the radiologists, postgraduates, and the students also that who have taken a time out to in this busy schedule and be a part of this webinar. And from Walters Kluwer, we assure you that we'll bring out such more topics in different subjects also in the near future. Thank you so much, sir. Thank you so much for your time today.
Thank you.
Thanks, sir.